Hello, everybody. Welcome to the UVA Medical Center Hour. I'm Justin Mutter, the director of the Medical Center Hour, which, as many of you know, is a longstanding program of our Center for Health, Humanities, and Ethics here at UVA. Today, we're really happy to offer this event in partnership with the UVA Health Sciences Library as a History of the Health Sciences lecture. This series invites us to explore key topics in the history of healthcare, history of health professions that have shaped and continue to strongly influence clinical training and clinical practice in our own time. I especially want to thank Megan Cashwell, the Alvin and Nancy Baird Curator of Historical Collections with the UVA Claude Moore Health Sciences Library, for her wonderful collaboration and support in bringing this event to fruition. A reminder to all our participants, those of you who may be new to our audience, you can claim continuing education credit for your participation in today's Medical Center Hour. Please just follow instructions on the slides that will appear again at the end of today's event. Our time on Zoom today is in webinar format, so if you have questions for our speaker, please use the Q&A tab at the bottom of your Zoom screen to submit questions, which our moderator will follow. And I'm delighted to introduce our moderator for today's lecture, Professor Dominique Tobel. Professor Tobel is the Centennial Distinguished Professor and Director of the Bjoring Center for Nursing Historical Inquiry here at UVA School of Nursing. She's a great friend of the Medical Center Hour, and as always, we're very grateful to have her with us guiding our conversation today. Dominique.
Thank you. It really is with tremendous pleasure that I introduce today's speaker, Dr. Aram Alam. Dr. Alam is an assistant professor in the history of science at Harvard University. She specializes in the history of medicine in the long 20th century, with a particular emphasis on US healthcare, race, migration, and the political economy of care. Her first book, The Care of Foreigners, in which this talk is based, will be out later this year with Johns Hopkins University Press. And the book is going to be absolutely fantastic, so I encourage everyone to read it once it's published. Alongside this project, Dr. Alam completed an edited volume called Ordering the Human, The Global Spread of Racial Science, that will be out in May 2024. Her next major project explores logistics and medical tourism. Dr. Alam earned her PhD in the history and sociology of science at the University of Pennsylvania and went on to complete a postdoctoral fellowship in the Penn program on race, science, and society in the Center for Africana Studies before joining the faculty at Harvard. So without further ado, I am absolutely delighted to turn things over to Dr. Alam, who will be speaking to us today about the care of foreigners.
Hello, everybody. Thank you so much to Dominique, to Justin, Charlene, everybody who has helped to bring this event about. I'm very excited to share my work with you and hear your insights on this topic. So I will begin by sharing my screen. All right. So in this talk today, I want to explore the following question, which might seem like a simple question, and that's how does skilled labor or expertise get decoupled from its place of origin, and what are the mechanisms that make this possible? So in other words, how do you create and manage a transposable, commensurable supply of global medical labor? And what effects do these processes have on the immigrant experience? So this cohort of immigrants that I'm going to be looking at are foreign physicians, and they're no longer explicitly excluded from the US based on nativist anxieties through restrictive origin quotas. They have a different set of disciplinary strategies that their expertise was channeled through. So discourses of standardization and competency really came to the fore in helping to understand how this migratory regime was managed and this movement was took place. So in this talk, I really want to attend to this kind of regulatory process and the paper manifestations that allow us to see the kinds of contours of inclusion that are available to this configuration of migrant. So to illustrate what I mean, I will take you to Pakistan. On November 11th, 1976, Tahir Akbar was eager to be the first in line in the US consulate in Lahore, Pakistan. In a 2016 interview, he recalled arriving at the office a few minutes before it opened, waiting anxiously with documents in hand, checking and rechecking his paperwork to make sure everything was in order. Upon entering the office, he handed over a file, which contained a freshly minted diploma from King Edward Medical College, which you see on your screen, transcripts, and a certificate stating that he had successfully passed the Educational Commission for Foreign Medical Graduates exam, which I'll talk about in a little bit. And he told me this was commonly referred to as the ticket to America. The interviewing officer asked him one singular question, and he was granted permanent residency on the spot on the basis of his answer and his appropriate documentation. He interpreted the conditions that facilitated this quick turnaround in the following way.
When I came to the US, I always tell people they have issues with the Vietnam War. I got no issues because of them I got my visa. Because all the American physicians were fighting in Vietnam, and the US needed physicians. So I graduated on November 11th, 76, and December 4th, 76, I was here.
So he says that he has no issues with the Vietnam War. Because of the Vietnam War, he was able to gain quick entry into the United States. So just 3 weeks after he applied to come to the United States at the consular office, he arrived on December 4th, 1976 at New York's JFK Airport, ready to work as a foreign medical graduate. And a note on terms as I continue, I use the term foreign medical graduate because that is the term that was used during that time. It's not meant to be derogatory in any way. And in fact, my interlocutors continue to refer to themselves in that as foreign medical graduates or foreigners. So you'll hear me use that term. So Akbar really intended to follow his classmates and join this burgeoning workforce of post-colonial physicians providing care in under-resourced urban and rural communities throughout the country. By the time he arrived, this migratory route was well documented. It was initiated a decade earlier under the Hart-Celler Immigration and Nationality Act of 1965. And in this act, foreign physicians were invited into the US to provide care in exchange for legal status. However, in order to actually begin clinical practice, Akbar and his colleagues had to assemble a dossier of documents necessary to make them legible to US publics and US patients. So in this talk, I want to focus on the bureaucratic process and construct a very rough stepwise recreation of the bureaucratic procedures necessary for immigration and clinical practice. I argue that for foreign doctors, the paper life really becomes this foundational mode of recognition. Medical competency exams, transcripts, certificates of completion, reference letters, and licenses operated as vital regulatory mechanisms. And through this assemblage, foreign physicians' difference was simplified, normalized, and reconfigured to produce this supplemental labor force that could be marshaled in times of crisis, like the Vietnam War. Although documents could testify for a person, they also had this potential to falsify. And I will think through a case where that happens. So I will begin with a brief historical overview and then continue on to a case, think about the question of fraud, and end with this idea of cycles of crisis. On October 3rd, 1965, 10 years prior to Tahir Akbar's migration to the United States, Lyndon B. Johnson signed the Hart-Celler Immigration and Nationality Act into law. During the ceremony, he made the following statement.
This bill that we will sign today is not a revolutionary bill. It does not affect the lives of millions. It will not reshape the structure of our daily lives or really add importantly to either our wealth or our power. Yet it is still one of the most important acts of this Congress and of this administration, for it does repair a very deep and painful flaw in the fabric of American justice. It corrects a cruel and enduring wrong in the conduct of the American nation.
So he's doing what a lot of presidents do, which is hedging on immigration. Don't worry, US public, this bill is not revolutionary. It's not going to affect the lives of many. Nothing is going to change. It's just a symbolic gesture. But in fact, he was wrong because it did significantly reshape the lives of many. First, it changed the composition of the US healthcare workforce by expediting the entry of Asian foreign physicians, with India, Pakistan, and the Philippines being the largest sending countries to provide care for millions of Americans because there was an ostensible shortage of practitioners. This shortage was years in the making and disproportionately impacted marginalized communities. Congress convened special hearings to investigate factors affecting the crisis, and they discovered that while the supply of US educated physicians remained relatively stagnant, demand for medical services was increasing rapidly. And amongst the major causes for the increase were shifting social and political expectations regarding healthcare. By this, I'm referring to what scholars call the medical civil rights movement or increased medicalization. There was huge demographic changes happening during this period of time. Many babies were born. And there were older people who are the highest users of healthcare. And most importantly, the expansion of Medicare and Medicaid, which became law only 4 months prior to Hart-Celler's passage. So July 1965, we have the passage of Medicare and Medicaid, and then in October, we have the passage of Hart-Celler. So that's the number one way that it changed, is but also this was part of the Cold War security apparatus that was really intended to subvert communist advancement. So the Hart-Celler marked a political and symbolic shift from the previous Immigration and Nationality Act of 1924. And in the 24 Act, there were two bills. One was called the National Origins Act, and the other was the Asian Exclusion Act. And the Origins Act instituted a restrictive quota from Eastern and Southern Europe, and the Asian Exclusion Act banned immigration from Asian and Arab countries. So when LBJ was talking about the deep and painful flaw in American justice, that's what he was referring to. During hearings leading up to the Hart-Celler bill, representatives explained, quote, "Our unfair and unpopular immigration law discriminates against most nations of the world, weakening our position of world leadership and handing Moscow ready-made anti-West propaganda on a silver platter," unquote. So there's this fear that in this new era where you have these newly independent post-colonial Asian nations, these were really the sites where the Cold War battles were being fought. And these were ideological battles. And the idea was that immigration could be this useful weapon against communist ideology, that if you created these interconnections between the United States and these newly emergent post-colonies, that there was hope that they would stay within the capitalist orbit. So this immigration bill was interesting for two reasons, because it solved two major problems. One is that you could quickly recruit physicians to come to the United States because there was an ostensible shortage. And the next was that it was doing this political work, this ideological connectivity work. So using this rhetoric of liberal democratic values and global interconnectedness, a stratified foreign labor force was inaugurated in the United States. In the first 10 years of the Hart-Celler Act, approximately 75,000 foreign physicians, like I said, originating largely from South Asia and the Philippines, entered the US healthcare system to staff hospitals in underserved areas. So on your screen, you will see a graph and two columns in red. The one on the left is the number of US medical graduates per year, and the one on the right is the total, and that's the total of all foreign physicians. And the two columns on the right are just aggregating different kinds of visa structures. But I want to draw your attention to the numbers, and especially post 1965 and the increase that's happening. So there's a slight increase in US trained physicians happening, but there's a pretty significant increase in foreign physicians who are entering the labor force every year. And as you can see, at times greater than the number of US trained physicians. And in this, I want you to pay attention to the column that is in red, which is the number of people that are coming from Asia. So there's this huge explosion that happens, and post 1965, especially, the numbers increase significantly. So although Hart-Celler is facilitating the entry of these physicians, serious questions remained about who these people were and what kinds of doctoring abilities they possessed. So really, how could US patients and publics trust these foreigners with matters of life and death? How do you know if these people are qualified, and what does that even mean? So with this influx of labor really came this influx of anxiety. Charles Sprague, who's the dean of the University of Texas Medical School, articulated this sentiment when he asked, quote, when a foreign medical graduate comes to this country, his educational background, his goals and objectives, and the educational system he finds himself a part of do not necessarily match up, what must be done to ensure that they do eventually match up? So in other words, how does a system structured to produce a wealthy white male physician contend with individuals that challenge this kind of normative construction? And what mechanisms are necessary in order to create this commensurate supply of global medical labor? So in the early years of Asian physician migration, this task really overwhelmed the medical establishment as they struggled to figure out how to create standards and oversight procedures. And after many failed attempts to manage this peripatetic labor force, the Educational Council for Foreign Medical Graduates was given the task of figuring something out. So the stated goals of the organization were as follows: to give graduates of recognized foreign medical schools an opportunity to establish their qualifications for undertaking advanced medical training in the United States, and to provide hospitals, state boards with the means of identifying these foreign medical graduates who are qualified to assume places as interns and residents. So the question, as I started looking at this, is what does it mean to recognize? What does it mean to establish? What are the qualifications? And how do you do this work of identifying? This was a procedural feat that required this reconstitution of heterogeneity into standard forms, literally and figuratively. And you needed to assemble some kind of archive to verify your identity as well as verify your expertise. And through this institutional body, this became the site of validation and was responsible for providing answers to two questions regarding foreign physicians. One is, who are you? And the other is, what do you know? So the first step was successful passage of the ECFMG exam and a validation of medical credentials. The exam was routinely administered at US embassies as a recruiting tool for foreign physicians and consisted of two parts: a test of biomedical knowledge and an assessment of English proficiency. The most difficult aspect of this process, explained one physician, was feeling, quote, everything was a trick. Every question and every possible multiple choice answer. Educated in Hyderabad, he recalled his frustrations. I'm sorry, there's more audio. Or maybe it didn't play. Okay. more audio that disappeared. But so he said to me, quote, "The method was totally different. The approach was totally different. We never heard of multiple choice in India. In our system, they would give you 10 questions and they'll say typhoid. So you have to write, what is typhoid? What are the signs? What are the symptoms? What is the outcome? And you have to answer this in 3 to 4 pages." And he explained that along with this, you had to get used to different things because there was no concept of, as he says, incidence of disease in a certain population. And what he meant by that is that he wasn't asked questions like he was in the multiple choice exam in the United States about what is the prevalence of this disease in a white population versus a Black population. So he said the switch to multiple choice and these kinds of having to think in these kinds of statements, such as all of these statements are true except, combined with questions formulated using this probabilistic race-based approach to disease, really required foreign physicians to reformat their knowledge. So typhoid was translated into a disease identified from a list of choices with differential effects on racialized bodies that were likely never encountered by these physicians thus far in their medical training. So in this example, race became something that's totally decontextualized, biologically based, and somehow this independent risk factor for a disease divorced from the social and structural conditions responsible for these population level health outcomes. And he continued to explain to me that these different approaches where every question and every possible multiple choice answer was a trick indexed this kind of incommensurability in the epistemology of disease that had to be overcome. But if he was successful, he was allowed to get access to this ticket to America. And this was the certificate stating that an examinee from India with an MBBS or somebody from South Korea or a doctor of medicine in the Philippines had completed this first step towards becoming a standardized foreign medical graduate. So this document really operated as the primary object that could coordinate the next steps of the movement. It mediated between medical education and training acquired in country of origin and future possibility in the United States. So well after their arrival, foreign physicians faced questions and challenges to their expertise, often with paperwork operating as an alibi to deny professional opportunities and restrict mobility. So in the following case, I analyze with you a series of letters between a foreign physician and a local hospital administrator. And when conducting a close reading, the tenuousness of the foreign physician's position vis-a-vis the US medical establishment is made apparent. So this physician, his name is Dr. Upal Nilesh. He completed training at Bangalore Medical College in 1975 and migrated to the United States soon after. In 1988, after practicing in the United States for over 8 years, he attempted to start a private medical practice and applied for privileges at an Illinois hospital. And his request was denied by the Director of Medical Affairs for 2 reasons. One, the documentation provided had only his initials for last and middle names, and his medical school transcripts and certificates were hand-delivered to the hospital instead of mailed directly from the medical school. His reply to the director, I will, first I just want you to see it because he was very upset, and I don't expect you to read it, but want you to witness his anger. I'll take out a few quotes from there. And he was very upset and he said, regarding my last and middle names being initialized, I had enclosed a copy of an article from an Indian magazine, which I thought provided the explanation. All the documents I have in my possession have my name written that way. It is a cultural, geographic, and local practice from the area of the country I come from to write names that way. regarding the documents being hand-delivered to your office, it took me more than 3 months, several phone calls, and many trips from my relatives in India to the medical school to obtain the documents. I hope you would appreciate the practical difficulties in obtaining letters from 10,000 miles away for a graduate who completed medical school nearly 13 years ago. 26% of licensed physicians in this country are FMGs, and we are part of this country just as anybody else. And he goes on to say, you have letters and scores of other documents in support of my application from your US peers. To fool or convince all of you would make me very good at my profession. So I want to highlight the fact that he is equating his rejection from getting hospital privileges. For him, he sees this as some kind of, this is maligning his place in the United States as well. So I'm a part of this country, and as somebody who is a part of this country, I should be allowed to have access to these kinds of privileges as well. So there is this understanding that based on his profession, that is what constitutes his ability to be included in the United States. And then he offers up the US peers as, well, these people at least will vouch for me, these people that you trust. He received a terse reply from the director who said, I can't interview you or submit your application again. So the way that his name was written could not be accommodated within the US bureaucratic norms and forms. So neither additional cultural explanations nor an objective newspaper article could circumvent this bureaucratic determinism. In the end, unless he produced himself in these allotted formulaic spaces, he was unverifiable in the United States, which clearly destabilized his sense of self and belonging. So his defensive posture of, we're part of this country just like anybody else, indexes this kind of rejection about his presence in the United States and exasperation at this forever foreign status. So the second problem with the application was the method of document delivery, or more obviously, the possibility of falsified credentials. And at stake in this objection is this question of, what do you know and are you telling the truth? And while documents are assumed to contain authenticity and truth or the force of law, in practice, so much of this is contingent on the sites of production and the conditions of receipt. So the mitigating factors, such as the real practical difficulties in obtaining letters from far off lands, it wasn't good enough to shift the position. So for the document, and thus Nilesh's expertise, to be accepted and verifiable, it had to undergo this procedural guarantee to abate a more paranoid reading of the foreigner. And then finally, in the last sequence of letters, the director writes to him, I'm sorry that your medical school fails to answer your requests for transcripts to be sent the right way. It does not reflect well on them. So as I said, he tried to persuade the medical director by additional letters and arguing that if I give you testimony by your US peers, they can vouch for me, that this will make me legitimate in your eyes. And these additional letters, I argue, really supported and indexed this hierarchy of credibility that elevated the reference writer's testimony over his original appeal. So if his attempts at veridiction were unsuccessful, his trusted US compatriots would potentially be able to vouch for him. Ultimately, the case had an unfavorable outcome. The director told him that he has been ordered to discriminate against incomplete applications. And so in this response, what I also see is this evaluative judgment that gets displaced onto the application being incomplete or incorrect. So in the years to come, foreign physicians experienced these kinds of deferrals, lack of ability to get employment in places, rejection based on these kinds of things. And they finally organized and hired a lobbying firm and waged a political battle against traditional organized medicine and the US government, urging them to remedy discriminatory practices in the system. So here you see a compendium of discrimination cases that was put together by foreign physicians in 1989. And they, at this point, were just so frustrated and continually made the argument that we've come to the United States because you've asked us to provide employment or provide care in these communities and these hospitals where US trained physicians are reluctant to go. And in addition to that, then anytime we try to move, switch cities, switch hospitals, we run into all of these kinds of roadblocks. So here are just a few of the examples that were collected by this lobbying firm. One was for a hospital in Wisconsin, and the physician who was trained at the same place as the first physician that I introduced you to was denied privileges because he was born in the wrong country. Another couldn't receive a license because the board, to make this just a little bit larger, refused the license because they needed information from Topiwala National Medical College, the CV of all professors that taught anatomy, physiology, et cetera, was required for the license. But India doesn't publish these kinds of things. And so the question that was constant, there was always a set of questions that were put to these physicians. And in conversation with one of the most prominent organizers for foreign physicians, he explained to me that foreign physicians were required to collect data in particular ways that often caused these starts and stops and delays in their lives. So examples include whether and to what extent teaching staff published research articles, the quantity and quality of basic lab equipment in their medical schools, the number of books available in their medical school libraries. And he really interpreted these extra forms and these questions as an exercise in creating and maintaining kinds of difference, that this was a technique to provoke feelings of inadequacy and shame through the use of forms and emotionally evacuated bureaucratic procedure. So always implicit in the question of the foreign physician is whether they were a fraud. So the qualification question, what is it that you actually know? And they arrived at a time when the status and authority of the medical establishment was in decline by the mid-20th century. And so physicians really feared that these newcomers would further dilute the image and integrity of the profession. Nevertheless, it was very difficult to deny their importance, as you saw in the graphs that I showed you earlier. In 1977, James Dickinson, who is the Secretary of the Department of Health, Education, and Welfare, reported between 1963 and 73, approximately 65% of the net increase in the physician to population ratio is attributable to foreign physicians. Nationwide, approximately 1/3 of the graduate medical education positions, internships, and residencies have been filled by foreign physicians. In 72, which was a peak year, 46% of new licenses to practice medicine issued in this country were issued to foreign physicians. So I just said a lot of numbers, but the gist of all of that is foreign physicians were in abundance, and especially during this very, very vital moment in US healthcare. Yet instead of acknowledging their integral function, organized medicine maintained this fraught relationship towards these practitioners, perpetually haunted by the questions of who are you and what do you know? The dean of Columbia Medical School voiced this concern in the New York Times, where he said, the result is the creation of two standards of medical care. The first for patients treated by first-class US medical graduates, and the second for patients being treated by foreign medical graduates of unrecognized medical schools. And there were these additional alarmist accounts in popular media. So one article of a fake doctor who performed brain surgery, along with social scientific studies entitled The Case of the Missing Foreign Medical Graduate, suggested also that there existed this illicit, unlicensed, underground network of dangerous medical practitioners who were bypassing standard bureaucratic control. The authors of this case of the missing FMGs estimated approximately 33% of foreign physicians who entered the country remained unlicensed and missing from any official registers. And they concluded that better long-term accounting mechanisms were necessary. But in the meantime, I asked the question, well, where were these practitioners? So if they're missing, they're unlicensed, but they're still in the United States, where do they go? And the same year that study was published, an article in the New York Times investigated the same question and found that these practitioners had infiltrated the profession and were practicing without supervision, unbeknownst to the patients. Quote, the patient might not know that the doctor was unlicensed. Some do surgery in operating rooms or in emergency wards. Others give anesthesia. Many practice psychiatry. Altman explained, who is the author of the piece, that these mostly Asian unlicensed individuals were called doctor because they held medical degrees from abroad. But contrary to his characterizations of this unqualified underground, what I found was that these physicians were readily incorporated and exploited by the medical system through multiple avenues. Another article in the New England Journal of Medicine entitled Foreign Medical Graduates and the Medical Underground investigated the involvement of these physicians in the daily functioning of hospital life and patient care. And the study revealed the following, quote, unlicensed foreign physicians are usually employed under non-physician titles. They're taking night calls, they're covering emergency rooms, they're delivering babies, prescribing pre-anesthetic medication, writing X-ray reports. They're doing history and physical examinations. Some of those known as pathology assistants are reading frozen sections on which a surgeon determines whether or not to do a radical procedure. Some of them are doing fluoroscopy. Some are doing minor surgeries, and a few are even completing major operations. So what it turns out is that hospital administrators were employing this quote unquote medical underground as a cost-effective strategy during a time when hospital operating costs were rising and budgets were declining. Dr. Weiss, who is the author of this medical underground study, explained that these physicians, they could be employed and they can't demand the same wage that they would get if they were fully qualified. So the physician that I introduced you to at the beginning, Tahir Akbar, this is how he began in the United States at NYU's main hospital. He arrived in Manhattan with $500, the maximum amount of cash one could carry overseas, and began calling hospitals in search of employment. He had yet to obtain his license or assemble the appropriate documents that he needed, but he recalled his first employment experience in the United States. Quote, he said, I was willing to work for free. I was willing to volunteer. In February of 1977, I happened to call NYU, and they were one person short in their intern year cohort. At that point, I had exactly $1 left in my pocket, which is such a standard immigrant narrative trope. And I showed up for the interview. They said, we can't hire you as an intern, but we'll hire you as a sub-intern for $16 a week. So I started working there as a sub-intern. We call them killer interns because of the amount of work that's dumped on you. And I worked just like an intern. After about a month of that, my resident went up to the chairman of medicine and said, you know, you're exploiting this poor, scared immigrant. He's a physician and you're treating him like dirt. You should pay him some more. So he was eventually given a small raise and continued working in this capacity for another 5 months. And he said that if he completed the required tasks, this prestigious medical center was willing to keep him on staff, irrespective of his documentary status. So I want to think with him in this case because it illustrates the ease with which professional norms and expectations were ignored and replaced with these available tropes of foreignness and cheap labor. So these racialized scripts and practices readily and repeatedly deployed against those considered unskilled made clear that expertise could only mitigate the precarious and devalued social position of the foreigner to a limited degree. So hospital administrators manipulated both the immigration and the medical system in order to maintain their staffs. There was, in 1977, a congressional hearing on foreign medical graduates, and U.S. Representative Joshua Ailberg, who presided over the hearing, he asked, quote, "Did not the hospitals in many cases take advantage of foreign physicians and use them as virtually indentured labor?" And he was saying this because what hospital administrators were doing was prolonging residency periods. They were allowing foreign physicians to come for what was considered unapproved periods. They were just even creating unofficial residency programs, all to make sure that they could find staff, especially in underserved communities. So this question about whether this was virtually indentured labor remained unanswered, but the point was made that hospitals were actually manipulating this immigration mechanism in order to secure their staff, and that a better system with protections for immigrant physicians was necessary. They felt taken advantage of the medical system, treated as, quote, second-rate doctors working in some small hospital, some ghetto place or asylum, quote, one organizer explained to me. So in my final moments, I'd be remiss if I didn't spend a little bit of time reflecting on our recent pandemic experiences and what this event has laid bare. So in many ways, my project ends where it began, in this state of terror with declarations of crisis. 60 years ago, it was a doctor shortage crisis while communist threats loomed. And in our pandemic moment, in the name of biosecurity, the foreign physician is asked to provide care on the front lines. In the first months of the pandemic, during the height of Trump's xenophobic rhetoric, in his proclamation from June 2020, all labor was suspended, entry of labor was suspended to the United States, except there was one notable exception. Healthcare professionals able to, quote, provide medical care to individuals who have contracted COVID-19 were still welcome to enter the country. And this authorized the State Department to issue mission-critical visas to foreign medical graduates. So the AMA, which has historically taken a negative to lukewarm stance on immigrant physicians, was highly supportive of this position and did significant advocacy work to ensure that this exception was included in the proclamation. In several public letters to officials, AMA executive, the CEO of the AMA explained that non-US citizen international medical graduates, so these are the foreign physicians that I was talking about, help play a critical role in providing healthcare to many Americans, especially in areas of the country with higher rates of poverty and chronic disease. Nearly 21 million people live in areas of the US where foreign-trained physicians account for at least half of all physicians. Individuals with serious chronic medical conditions, including diabetes, are at a higher risk of experiencing serious complications from COVID. Our non-US citizen IMGs play a vital role in caring. And he continues in another letter, is more critical than ever to ensure that the US has a fair and efficient immigration system that strengthens the American healthcare system and advances the nation's health security. So the entanglement between immigration, biosecurity, and these physicians, I think, is really laid bare in these kinds of statements. So in recognition of these physicians and the work that they were doing, Biden also said that just as India sent assistance to the United States, and this assistance was in the form of labor, that the US was going to help India in this time of need. And that meant that they sent some PPE, some oxygen supplies, and some funding to expand vaccine manufacturing. Meanwhile, in India, which also had, alongside the United States, the highest rates of COVID, there was a huge dearth of medical professionals that were available to provide care over there. So although my project explores this migratory path between South Asia and the United States, the movement of healthcare providers from the global south to the global north is not unique to these two locales. In 2021, the United Kingdom's NHS hired more doctors from the global south than those trained in the UK or the European Economic Area. Australia also is part of this. And predictably, data from the United States, the UK show that amongst the first healthcare providers to succumb to the effects of COVID were immigrant physicians and nurses. And given the global scale of this problem and our recent pandemic lessons, what then is the ethical responsibility of the world superpower, and what does something like pandemic preparedness actually mean? And I would argue that building and supporting a sustainable healthcare workforce has to be the foundation for any global preparedness plan. Thank you.
Thank you so much, Aram. That was fantastic. I just want to remind audience members that if you have a question, please put it in the Q&A box, and I will share your questions with Dr. Alam. So while you're pondering your questions, I have a few of my own. You know, it was really striking to see the table of different internationally educated physicians and where they were coming from. And obviously you said that India and Pakistan and the Philippines were the largest exporters of foreign medical graduates. So can you speak to like why those locations, those post colonies in particular, and also, you know, what has been the implication for medical care in those countries that are sending their expert physician labor to the US?
Thank you so much for that question. So those countries were, it's these legacies of colonization that have really allowed for the excessive number of physician migration from these places. So during colonization, the British were very invested in creating and maintaining biomedicine within India and now Pakistan. And so there was a lot of things like the King Edward Medical College were established during the times of British colonization. And so there were all of these, it was really a robust infrastructure that they helped to create. And what that allowed for is this kind of legibility across these spaces. And so medical training happened in English, many of the same kinds of training that were happening in the UK and some versions in the US eventually were also happening there. So there was the mobility of information transfer was a lot easier in those spaces. Also, English being being the medium helped a lot in facilitating this. And especially in the early days of the NHS, the physicians from South Asia there was a very smooth transfers that could happen to the UK. So the regulatory mechanism was not nearly as robust as it is now. And so much of the NHS, there's great work on this, has really been established by foreign physicians from South Asia who were doing similar work. In the 1960s, immigration to the UK became more restrictive, and they started implementing more regulations and tests that physicians had to take. And so then there's this diversion that happens because physicians then decide, well, why should I go work in a salaried system as a government employee that has all these restrictions to entry when I can go into this free market space and make a lot more money? The Philippines, also legacies of US colonization. US colonized the Philippines until 1946. And part of the work that was happening there was really about establishing this biomedical infrastructure. And so what has interestingly happened is that the Philippines now thinks about physicians as an export commodity and has really, really produced this robust economy around producing physicians because the remittances that come back help the economy there so much. In India, the case is a little bit different, where there's more of a desire to prevent migration that happens in certain moments. So during the pandemic, they were trying to incentivize physicians to stay and work in communities in India. And the power of the US is so great. The magnetism of that draw is so great that when you have systems that have been well established, people are going to take advantage of those kinds of systems.
Thank you for that. We do have a question in the chat. Someone is asking about the effects that this history that you've shared with us, what impact that has had on patient care or patient outcomes. Do you have any sense of that?
I think it's in the communities that foreign physicians have been able to work and have staffed it. Supposedly, there are these two economists, these two graduate students who just came to me, and they're trying to work on this. So part of what the difficulty in all of this is that there isn't a lot of robust data to help understand how long physicians are staying in certain places. Because of the ways that immigration has been so piecemeal and chaotic, and people come through different routes and then they get lost in the system or create their own practices. Finding this long-term data of how long people have stayed in certain places and then the health outcome as a result hasn't been that easy to actually find. So these graduate students were able to track a few hospitals in Appalachia in the United States that really kept robust data long-term about this, and that's part of the work that they're trying to do. And they have, their initial findings suggest that there has been a positive outcome just by virtue of the fact that there are practitioners that are there that would not have been there otherwise.
Yeah, thank you for that. We have another chat. This is from Justin Mutter. This is a great lecture focused on the systemic discriminatory practices throughout the history of the US IMG, FMG policymaking. That is major and powerful standardization institutions such as the AMA, hospitals, state boards of medicine, etc. Thinking about the entire book, which we're all excited to see, did your research uncover any community level perspectives? For example, physicians who embedded themselves in marginalized rural communities in the US, how did these communities engaged with international medical graduate physicians?
Yes, thank you for that. Yeah, it was an interesting thing because there's the two cohorts. One cohort generally would go to rural communities and leave and move into suburban areas after they've finished their probationary period of care. And the other really established themselves as these practitioners. They sometimes would be the only physician for 200 miles or the only cardiologist. And I've found that they really did embed themselves in the community. I laugh all the time because one of the common things that I heard was that, especially with these rural physicians, they all learned to golf. And I was going to have one of my chapters or a section, called something about golfing. But it was this way that they became almost these patron-like figures. So starting scholarships in these communities. And then what also would happen is that they would invite other physicians, especially once they rose in the ranks of hospital administration, to come and work in these areas. So they in certain rural communities, you find pockets of immigrant physicians that stayed and maintained practices and really had lives in these areas. And, Abraham Verghese's My Own Country, which is an autobiographical text, is a really great example of this, of these embedded communities in particular areas. But my experience is that by and large, there was an out-migration more than there was a willingness for these physicians to stay in these communities. It was the likelihood of them leaving was much greater than the likelihood of them staying.
Yeah, thank you. I'm curious to hear you speak to we see the lawsuits that many of these immigrant physicians filed because of the discriminatory experiences they were facing. Were they engaged in other kinds of advocacy and political activism? And could you say a little bit about that?
Yeah, they became really very much engaged in this. And, I think when you have elite migration, which is not something that's often talked about when we do histories of migration, um, this is different because they're able to accumulate a significant amount of economic capital. And through that, having money allows you to be influential in different kinds of ways. And so these physicians really understood that and started to take advantage of the US political system. So even things like hiring a lobbying firm, understanding that that is a route that could potentially be available to them. One of the physicians that I became very close with, he would close his practice every Wednesday afternoon and go down to I don't know, the restaurant or the bar that the congressional people would hang out in. And he spent just having conversation. And so just even understanding that that was a mode of being able to influence politics and to get people's ear. And so he's like, yeah, I was sitting there and I talked to Daniel Moynihan, who would come through, and I talked to all of these other influential senators and was able to explain my case. But being able to understand and access how to access those kinds of people and those avenues, I think they really did that kind of advocacy work. And then in addition to that, there was a huge network of ethnic newspapers that became vital in sending messages around and communicating effectively. And we were supposed to do this when Vivek Murthy came and last semester, and one of the people that I interviewed for this ethnic newspaper, he kept talking about the fact that he felt he was instrumental in getting Vivek Murthy to his appointment through, because all of these physicians, he sent out a message in this ethnic newspaper, and these physicians responded, and they said, the message was, go and call all of your Congress people and tell them that they have to support Vivek Murthy's candidacy. And ostensibly it worked. So, I think they're able to get this kind of literacy of when you have money, what are the kinds of things that you can access?
Yeah. Well, thank you so much, Dr. Allen. This has been really remarkable and fantastic. And I know I am very excited to read the book when it's done. So thank you for sharing with us today.
Thank you so much. I really appreciate all the questions and the time and the energy, and I know it takes a lot. So thank you so much.
Well, thank you. I'll add my thanks to that, and really appreciate everybody's participation today. Thanks to Professor Allen, thanks to Professor Tobel for guiding us in this discussion. On the topic of the Surgeon General, I have a few announcements in terms of upcoming medical center hours. So on March 6th, we will be hosting Marc Lipsitch also from Harvard, who will be delivering our annual Hayden-Farr lecture, which is Everything Keeps Changing, Lessons of COVID-19 for Pandemic Surveillance. And that is both in person and on Zoom. Again, that's March 6th. On March 18th, which is actually a Monday, a different typical day for us with Medical Center Hour, that is actually going to be the first ever National Health Workforce Wellbeing Day, sponsored by numerous organizations. And in celebration of that, we will be holding an event for people in Charlottesville and UVA, an event at McLeod Auditorium in the School of Nursing from noon to 1 p.m. to be led by the UVA School of Nursing's Compassionate Care Institute. We will premiere a video with the recording of the Compassionate Care Institute's Lily Powell discussing wellness and well-being with U.S. Surgeon General Vivek Murthy. We're very excited about that, and we will talk about the video in breakout groups and a panel discussion following that. So be on the lookout in your emails for those opportunities. Thank you again to our speaker and to Professor Tobel, and we will see you all next time.